Hello, Vienna Adi, Dr. Paul Morgan, or hello, my name is Dr. Paul Morgan. I'm a consultant intensivist at the University Hospital Wales in Cardiff and sepsis lead of the Cardiff Vale University Health Board. Today is World Sepsis Day 2021, the 13th of September. About 18 months ago, we started to see the beginnings of the terrible effects of the COVID-19 pandemic. This meant that a lot of the things we used to do for World Sepsis Day became unviable. We've been unable to hold public events, and education events have also been severely curtailed, pretty much being an online-only provision of healthcare education. And this has also been in the context of NHS staff being stretched to capacity and beyond. So, asking them to be involved in education and quality improvement work other than directly related to the COVID-19 pandemic has been extraordinarily challenging and basically largely hasn't happened. So you could argue that we don't seem to hear so much about sepsis these days. Worldwide health news reporting has very rightly focused on the direct and indirect effects of the COVID-19 pandemic. Obviously, in terms of the effect of the infection on people, many thousands of people have been affected by COVID-19, myself included. Luckily, I had it mild. Many have ended up in hospital, severely ill. And of course, many thousands have died from infection in the UK and worldwide. And then, because the healthcare service has been so swamped with COVID-19 patients, this has meant that the knock-on effects in other aspects of healthcare have been very significant, with waiting lists growing and backlogs for healthcare seemingly growing on a daily basis. However, sepsis is still out there. It's harming people, it's maiming and killing. And there's a number of links here to various stories in the news that could just curate, in a matter of a few minutes by searching the BBC News website. So, sepsis hasn't gone away. Many effects of severe COVID-19 are actually due to viral sepsis with shock and multiple organ failure, particularly acute lung injury. A statement from a wide variety of intensive care societies across Europe and the Global Sepsis Alliance and the Society of Critical Care Medicine in the USA have made a joint statement to give some more information on that. So, sepsis. I just say we're still having issues with recognition, diagnosis and treatment of sepsis. Despite many years of trying, we don't yet have a sepsis screening tool which is good enough to recommend universally. It's debatable as to what would be the best option just at the moment. Probably the best we have at the moment is to use the NEWS 2 score plus suspicion or evidence of infection. We could use the UK Sepsis Trust's red flag sepsis criteria. We could use the SOFA score, which is probably best used inside an intensive care unit, or the distillated Q SOFA score, as was proposed when the third international sepsis definitions were published in February 2016. The National Institute for Healthcare Excellence has also suggested a risk stratification programme, which has been now merged with that of the UK Sepsis Trust. And probably the one thing we can dispense with is actually what we used to use before, which is based on SIRS criteria. SIRS was essentially thrown out of the sepsis definitions when those third international criteria were published, some 5.5 years ago now. So the problem is that none of these tools on their own are sufficiently robust. And what you could argue as well, is there a role here for using more and more information, maybe in the form of some sort of artificial intelligence or machine learning? We don't know. There's been quite a few studies looking at this. Again, none are yet to prove good enough to get out into everyday clinical practice. We don't have a single diagnostic tool for sepsis, so we're relying on surrogates, mainly in terms of tests for infections such as CRP or procalcitonin or white blood count cell levels. that in combination with clinical observations grouped as, for example, News 2. We do, however, know that comorbidity plays a significant role in determining outcome from sepsis. The more things you have wrong with you to start with, the less likely you are to have a good outcome. And the other thing which is important is recognising that clinical frailty also plays a significant role. Again, if you are elderly, frail, again with multiple healthcare issues, then your chances of surviving sepsis and septic shock are greatly reduced compared to somebody young, fit and healthy. We do, however, know that quick treatment of sepsis can be life-saving, such as delivery of the sepsis 6. However, before we get on to treatment, we really should think about prevention. We know that sepsis is the body's response to infection, being a gross overreaction. As I say, defined as a dysregulated host response to infection that harms the body's own organs and tissues. So clearly the way to prevent sepsis in the first place is to prevent infection, and therefore we need to focus on issues such as hand hygiene, clean water, high food standards, cleaning and dressing of wounds, good quality infection prevention control, and of course vaccinations where appropriate. And certainly when we talk about viral infections and viral sepsis, such as we see with COVID-19, vaccination has been an absolute game changer in the way COVID is presenting now in patients requiring hospital admissions. There's also a role, probably in some cases, of prophylactic antibiotics in certain surgical settings, but as a general rule, providing antibiotic therapy just in case isn't always the best thing to do, as it has a potential to breed antimicrobial resistance if used inappropriately. Sepsis survival is a big problem. We've seen for quite a long time now that many sepsis survivors are left with a variety of medium and long-term healthcare issues. Various physical problems, poor cardiac function, poor mobility, hair loss, desquamation, and there's also a significant number of psychological problems in terms of, poor concentration, poor memory, inability to cope with everyday life, survivorship guilt sometimes in some people, why was I the one to survive? Of course, we're now seeing similar issues with the COVID pandemic in terms of what's termed long COVID. However, you could argue that actually one of the benefits of the pandemic has been the recognition of the need for rehabilitation services to be significantly enhanced, establishing what are termed long COVID clinics in many hospitals and healthcare settings across the UK. And I think we now need to press the case for these services to be extended to sepsis survivors, given the commonality of the problems that these various patient groups see. So thinking about sepsis treatment now, several campaigns in the past 20 years have been put out to try and improve sepsis treatment, which quite frankly before about 2001 was very much hit and miss, and with no good evidence as to what was good and what was not so good. So we've seen the Surviving Sepsis campaign, originating as an international campaign, but coming out to the USA. In the UK, the Survive Sepsis campaign was established to try and make things a little easier to understand and clearer. We've had the Global Sepsis Alliance and, of course, the establishment of World Sepsis Day some years ago now. A number of charities have also been set up that aim to do things such as improve public awareness of sepsis, improve sepsis education of healthcare professionals. And so from Scotland, we've had the Fiona Elizabeth Agnew Trust. From the USA, we've had Sepsis Alliance, we've had the Australian Sepsis Network, and of course in the UK, we've got the United Kingdom Sepsis Trust. So one of the things the UK Sepsis Trust did was, following on from the Survive Sepsis campaign, was establish the Sepsis 6, the fundamental basis for treatment of sepsis across the UK, being something that was feasible to deliver outside of an intensive care unit, such as in the general ward or in the emergency department. The Sepsis 6 has undergone a number of tweaks over the years, but what is clear from The research done on the effects of the sepsis 6 and on other sepsis management programs across the world is that the single most important aspect of the treatment is timely and appropriate antimicrobial therapy, antibiotics. Now, this is the problem because while we have many good antibacterial antibiotics, we have some good antifungal antibiotics, we don't have many antiviral agents that are particularly effective, and certainly none as yet confirmed to be beneficial in treating the SARS-CoV-2 infection, the cause of COVID-19. We have a major sense of responsibility to ensure that we use our antimicrobial agents appropriately. So, antibiotic or antimicrobial stewardship is vital to reduce the risk of antimicrobial resistance leading to untreatable infections in the future. Finally, we need to think about keeping sepsis a healthcare priority. As the vaccination program extends across the world, we hope that the SARS-CoV-2 pandemic, COVID-19, will come to some sort of end, frittering out. Maybe it'll be at the end of what we're going through now in terms of the third wave. Maybe it'll become a low-level endemic infection, such as we see with other coronaviruses that are, causes of the common cold. We need to ensure that public awareness of the risk of infection leading to sepsis is maintained. And again, maybe this could be one of the benefits of the pandemic, to keep fresh in the public psyche that infection isn't something which is nothing to worry about. It can cause significant harm. It can lead to people dying unnecessarily. We need to also ensure that the investments made in critical care and rehabilitation services as a direct consequence of the pandemic are maintained and strengthened to provide better care during and after serious illness. And we also need to reinvigorate and refashion sepsis education to the public, to healthcare workers and to governments. I remain hopeful that we can make significant improvements in the recognition, treatment and outcomes from sepsis in the coming years. Thank you for your attention. Bye.